The next talk title, Is There a Difference in Tests for Monitoring Infused Factor VIII, presented by Dr. Steve Kitchen. Dr. Steve Kitchen is the lead clinical scientist at the Department of Coagulation at the Sheffield Hemophilia and Thrombosis Center, Sheffield Teaching Hospital. He's also the scientific director of UK National External Quality Assessment Scheme for Blood Coagulation and director of WFH International External Quality Assessment Scheme for the blood coagulation. Again, we welcome Prof. Dr. Steve Kitchen to share his presentation.
So I want to thank the Saudi Hematology Association for the invitation to participate in this session. It's sad that we cannot be face-to-face. I came in the past to Saudi. It was a pleasure. On the other hand, I think it's good that we take the chance to do this remotely rather than not do it at all. So in the next 25 minutes or so, I've been asked to discuss other differences in assays used for monitoring infused factor VIII. These are my disclosures. So we should first remind ourselves that there are a number of different types of factor VIII assay. The most commonly used assay, one-stage APTT-based assay, increasingly used chromogenic factor VIII assays. There are others, some of which have been only recently available. Fluorogenic assays, point-of-care assays are in development. They will be, I think, very interesting when they arrive. There are antigen assays already available commercially, and also even a mass spectrometry assays in development from articles in the literature. By far the most commonly used factor VIII assay is the one-stage assay based on APTT. Actually, I think it's a bad name. There's more than one stage in the test, but nevertheless, it's the title that's used, and it's one that we should continue to use, I think. So this slide shows a one-stage assay and the components. We have factor VIII deficient plasma. We make some dilutions of a reference or calibration plasma. We mix those two reagents, and we perform an APTT on that mix. Just as we have many different types of APTT reagent available for APTT determinations, all of those reagents are also used in one-stage factor VIII assays. And so there are a number of variables associated with the reagents, the activators, the phospholipid concentration, the phospholipid composition. So there is plenty of opportunity for different results as a consequence of different reagents. We make a calibration curve, plotting concentration against time, and we'll repeat this for the test sample. So it's quite a straightforward process. Chromogenic factor VIII assays are increasingly available and increasingly used in a number of regions. The principle is different. It's shown here on this slide. We have usually a higher dilution of the test sample. That has some implications, some advantages in relation to losing the impact of interfering substances. The kit reagents contain 9A and 10 calcium phospholipids. Some kits use thrombin, others use prothrombin and factor V. But at some point during the assay, thrombin is required. We get full activation of factor VIII. We have an incubation period during which 10A is generated, and then we determine the concentration using a color change reaction, a chromogenic substrate, a chromogenic reaction. It's important that haemophilia centers have access to both of these types of assay. This slide is a recommendation from the recently updated WFH, World Federation of Haemophilia, guidelines on management of haemophilia. I'll show you the full reference in a later slide. But this slide, this recommendation, reminds us that if we wish to detect all cases of mild haemophilia A, we need to use both a one-stage and, in addition, a chromogenic assay. Even if one of those results is normal, there are cases only detected by one of these two. Most cases picked up by both assays, a small proportion only detected by one. So haemophilia centers, even before the question of infusion and monitoring, haemophilia centers require access to both tests according to this recommendation. We've known about the possibility of assay-related differences in the measurement of infused factor VIII for many years. This slide shows some data from a proficiency test in exercise, UK NEQAS, a test sample analysed by 78 labs doing one-stage assays, same sample analysed by 16 laboratories doing chromogenic assays. These were the average results. They're not the same. It's about a 30-40% difference, higher by chromogenic. This particular problem could be resolved, could be removed if the one-stage assay, one-stage assay is calibrated not with the usual human plasma standard, but instead is calibrated with a concentrate standard, a product-specific material, in this case, the same as the infused material, refractor AF. So assay differences, been around for many years. One option to remove this is shown here with a product-specific calibrator. This is not always straightforward. So thinking in general about assay differences, we now have a number of publications reporting differences in factor VIII assays in the presence of a number of different types of infused material. Full-length recombinant factor VIII, also B-domain deleted, I just showed an example, and in addition, particularly in relation to extended half-life, EHL, extended half-life factor VIIIs, and other modified factor VIII products. We change the molecule, we can generate differences between different assays. If there's a difference, how big a difference is important? Well, I think that probably depends on the level of activity, but in particular, there is no internationally accepted consensus. 20% difference is perhaps considered acceptable in some publications by some experts in the field. A number of assay studies have talked about 25 or 30% difference between two assays as being enough to matter, enough to start to change the patient management. And I think we should focus only on differences that might change patient management. If there is a difference, how do we know which is the truth? Which number should we use? Well, I think we can make some comments about this. We know that clinical trials are run in order to identify which is the correct dose, which is the appropriate dose. And of course, in those trials, the units come from the labeled potency of the vial. It means that the clinically relevant result comes from the potency assignment. So in the lab, I think we want an assay which gives a similar number to the one used for potency assignment. What are the implications? Well, if we select a lab assay that gives a lower result, and if that number is used to make adjustments to the patient's treatment, it would generate additional infusion, material that's over and above what's required clinically, the potential for overtreatment. And of course, this is a waste of a precious resource. Even worse, I think, if we choose in the lab an assay that gives higher results than the potency, overestimates, there is a danger. If that number is used to make a dose adjustment or to influence the number of units given, in that case, we may give insufficient factor VIII, and there is the risk of undertreatment and all the consequences. So this, I think, is a potentially relevant and serious situation. We don't want to do this. I mentioned previously a recent update from the World Federation of Haemophilia, and this is their guideline document. You can see the reference on the footer of this slide. And there is included in this document a section dealing both with laboratory diagnosis, but also monitoring. And a common feature of whichever product is used, a common recommendation from World Federation of Haemophilia, we in the lab should select an assay that's been checked and validated for use with the specific concentrate being used. We have to be sure the assay is suitable for the concentrate in use. We now have a situation in which a number of modified forms of factor VIII are available. This is really good for patients. We've got extensions to half-life generated by pegylation in 3 products here, all now licensed for use in some countries. We've got a modified form of factor VIII here, a single chain molecule, and we've got other available modifications. and some of these at least have an extension to half-life, and of course that's good for treating patients. But what about the implications for assays? The first of the extended half-life modified factor eights to be licensed in some countries was Electrolyctate. It has different brand names in different regions. These are data from a proficiency testing exercise. A number of laboratories assayed a couple of samples here on the right, samples containing Electrolyctate, and the results are not identical between the two types of assay, about 20-25% higher by Chromogenic. How is the potency label? It's done by Chromogenic assay. The advantage then is with the Chromogenic assay. 20% difference, probably it's acceptable. I think it's acceptable to use one-stage or Chromogenic assays. This difference is small enough to not have an adverse impact on patient management. These are some published data from a field study looking at samples containing Electrolyctate in the blue columns, or another sample containing Advate, and the pairs of columns are results in a series of different laboratories. And you can see a shaded green area. The pairs of columns are all inside that shaded area, indicating that each of those laboratories recovered results somewhere between 75 and 125% of what was anticipated, expected, based on potency label. So any of these assays suitable for use. And these kind of data are what have led to this recommendation from the World Federation of Haemophilia that it's acceptable to use one-stage or chromogenic factor VIII assays for monitoring Electrolyctate. I haven't seen any evidence that any of our routinely available assays are unsuitable, so no important assay issues. What about pegylated factor VIII? So these are some data from a field study looking at the Bayer pegylator product, now has the brand name GV, a series of different one-stage assays used in the field study, and here is the expected potency. 100% would be recovering the expected labeled value. Couple of reagents here, ActinFS, CK-Prest, overestimating relative to expected potency, unsuitable. A couple of assays here, one-stage assays, grossly underestimating, unsuitable. Same study, some chromogenic kits, here 3 different kits, all recovering really quite close to the expected potency. Any of these 3 kits, different chromogenic assays, suitable for monitoring this product. And these data are now published, and some of these data have led to these recommendations from World Federation of Haemophilia. Chromogenic assays are suitable, and selected one-stage assays. Others, not suitable. So we have to carefully select the right assay. A different option for pegylation and extension to factor VIII half-life used here by a different company, in this case Novo Norddisk. Publications talk about N8GP as the molecule. Its trade name Esperoct, now licensed in a number of countries. Some one-stage assay data here and chromogenic assay data on the right. A number of reagents here and here recovering close to the expected, suitable for use. Here's an assay which significantly underestimates. ABT-TSP should not be used to monitor this product. Recommendations from World Federation of Haemophilia. Once again, chromogenic assays, a common theme for all of the factor VIII molecules we've discussed so far. Chromogenic assays suitable, some one-stage ABTT-based reagents, but not others. Once again, careful selection of assay. A third extended half-life factor VIII, in which pegylation of the factor VIII has been used to extend the half-life. This is now the Takeda product, and this is from the field study. One-stage assays on the left of the slide here, chromogenic here on the right, and you can see the pegylated product here. And these are the targets, expected values based on potency label, and recovered values here for the one-stage assay, really very close. Some minor overestimation with chromogenic by close to 20%. In my opinion, that's close enough to be able to use any of those assays successfully. And these were the conclusions of this article. routinely available one-stage and chromogenic assays suitable for use without need for a product-specific standard. However, there was a later publication from a Swiss group, a Multilab study, I think 6 different laboratories, and they reached a different conclusion. So they've got some one-stage assay data here and some chromogenic assay here, and then they've got assays calibrated either with a local laboratory standard in the usual way, or instead the same assay calibrated with a specific standard, a product-specific standard. And what they noticed for chromogenic assays here was some marked overestimation if the assay was calibrated as usual with the usual human plasma standard. And they were able to see much better agreement to the expected levels if they used a product-specific standard. So there's a little bit of a conflict, I think, between these two publications, and that's why I think the WFH guideline advises at the moment that more laboratory assay data would help before making strong recommendations about which assays could be used. There are some extra data available from abstracts in meetings, a little bit of additional data. I think at the moment, if I were having samples from patients on this drug in my lab, I think I would probably use a one-stage assay with our standard plasma standard. I think we need a little bit more data to be confident in chromogenic assays. We also have available this modified form of factor VIII, Fstyler. It's a matter of debate to what extent it's an extension to half-life. Maybe there's some intermediate between some of the recombinant full-length products and some of the extended half-lives. Nevertheless, it's available, and this is from the SMPC, the company information, recommends the use of chromogenic assay, and that if a one-stage is used, this recommendation talks about applying a correction factor, and this is based on a publication which shows underestimation by about 40 to 50% in one-stage assays. Personally, I have some reservation about using correction factors in this way. I think it opens up the potential for transcription errors. And we looked at this locally in my own centre, shown on this slide, a number of different samples containing Fstyler at different levels, a number of different chromogenic and mainly one-stage assays. How close did we get to the labeled potency? Well, we did see some difference even after the correction factor was applied, close to a 50% difference here, each individually relatively close to the target, but nevertheless, particularly at this low sample, I think there's some significant overestimation here, and that could in principle have implications for dosing. So personally, I prefer the chromogenic assay in relation to this product, and indeed, that's the recommendation from World Federation of Haemophilia, use the chromogenic assay. We're in a new era where we have new options which are not conventional replacement therapy, let's say, one of which is this molecule, emicizumab, trade name Libra, a non-replacement for factor VIII. It's a bispecific monoclonal antibody. It recognizes human 9,9A and human factor 10,10A. It's very specific for human proteins. It doesn't recognize bovine proteins. Of course, in a patient, there will be no bovine forms, but in our laboratory assays, some of our kits do use bovine proteins. So that's relevant when it comes to lab assays. It demonstrates some surrogate mimic factor VIII activity and partially substitutes for factor VIIIa in the patient, and is therefore an attractive option because it's not neutralized by anti-factor VIII antibodies. Will we see emicizumab and factor VIII in the same sample in the laboratory? I think I'm sure it will happen. We have non-inhibitor severe hemophilia A patients under emicizumab therapy, and of course they may suffer traumatic bleeds, they may require surgery, and occasionally will be given additional replacement therapy with factor VIII during the emicizumab therapy. Half-life of emicizumab, about 30 days. It's still in the sample, even if that drug was stopped just before surgery, for example. So we will see both drugs present in the same sample. Of course, we'll also create that situation in the lab during a factor VIII inhibitor assay if we do this on a factor VIII inhibitor patient who is under emicizumab therapy, and we want to check the level of inhibitor. In either of those situations, recognizing that emicizumab is highly specific for human proteins, we should choose a chromogenic factor VIII assay in which bovine factor 10 is particularly important. The factor 10 is bovine, and then we can do this and measure the real factor VIII in the presence of emicizumab without interference. So another situation. We have new molecules coming through. This is a recently published clinical trial, published late 2020 on an extended half-life factor VIII created by fusion to von Willebrand factor, and there's some other components in the fusion protein, an FC portion, and some extension polypeptides. It's an attractive option in terms of half-life, 3 to 4 times prolongation compared to recombinant factor VIII, and that's a much more extended half-life compared to the previous molecules we've discussed. What about assay effects? So these are some data from the clinical trial. One-stage assay performed with these reagents, chromogenic assay, this kit. Both assays were calibrated in the study with product-specific calibrator, so with the protein itself. Even with that, there's about a 15-20% difference, higher results by one stage. So again, something to be aware of. Other options coming through, of course, are gene therapy for haemophilia A. Will that see an end to assay issues? It won't. Most of the studies reported so far have shown some difference between chromogenic and one-stage factor VIII assays. And here's an example. In this particular study, published in 2017, you can see here significantly higher factor VIII assays by one-stage assay compared to chromogenic. So the opposite way around to what has been reported in B-domain deleted recombinant factor VIII concentrates. Nevertheless, an important difference, and of course, this also must be kept in mind when interpreting assay results from patients under gene therapy with these products. Shown one example here. It's similar with some other products now published. And because of these gene therapy related effects, I think it's most welcome that FDA have called on industry to provide detailed information about assay effects, and that they are requiring this in advance of the license review process. So I think we can anticipate good data on gene therapy in advance of seeing this in our patients in post-licensing, let's say. So in conclusion, it's clear that not all factor VIII assays give the same answer in treated haemophilia A patients. Chromogenic factor VIII assays are suitable for monitoring standard half-life concentrates, plasma-derived, B-domain deleted, full-length recombinant, and in addition, extended half-life concentrates available to date. And so I think is an attractive option because that's not, some one-stage assays are not suitable for some products. Chromogenic assays suitable for all the products available to us just now. I think we do need some more clinical data for some products, as I've mentioned, including, for instance, some of the gene therapies, but it looks increasingly as though the chromogenic factor VIII assay may well be the assay of choice even in this setting, and we need more data in relation to other modified forms of factor VIII that will likely be available in future. Thank you for your attention.